Hello everyone, myself Dr. Prateek Garg. So today's topic is nasal polyposis. So what are the nasal polyp? So nasal polyp are nothing but an overgrown mucosa. Overgrown mucosa. Why these nasal polyps are happening? Suppose this is my nasal cavity. Suppose this is my nasal septum, and then comes there, this is my middle turbinate and this is my maxillary sinus over both the sides. So whenever there is a blockage of osteomeatal complex, it may be because of the DNS, it may be because of the turbinate hypertrophy, maybe because of the concabulosa, or maybe because of the chronic rhinosinusitis, where there becomes the fibrotic changes in the mucosa leading to osteomeatal complex blockage. So what happens? In the sinus, the ostium opening is blocked. Because of that, the negative pressure changes occur in sinus. Negative pressure changes occur in sinus. So because of this negative pressure, mucosa will start invaginating. Mucosa will start invaginating. There will be the overgrowth of mucosa, sometimes leading to nasal polyps. So this is one of the pathology how the nasal polyps are being produced. Because of the blockage of osteomeatal complex, the sinus mucosa may get invaginated inside because of the negative pressure, and this negative pressure will lead to indrawing of the mucosa into the sinuses, and with the time this mucosa will get hypertrophied, filled with the mucin, leads to formation of the polyp. So nasal polyps are polypoidal mass which are arising from the edematous nasal mucosa. The causes may be infection leading to the blockage of the osteomeatal complex, and typically in the infection there occur the AC polyp, enteroconal polyp. AC polyps are the polyp which are arising in the maxillary sinus. So because of blockage of opening of the maxillary sinus, the mucosa get invaginated, hypertrophied, leading to formation of the polyp, and these polyps then come out from the maxillary sinus and they will grow towards the choana, towards the nasopharynx. They will go inside the nasopharynx instead of coming interiorly. That's why this AC polyp is known as enteroconal. That means starting in the antrum is the maxillary sinus, and then proceeding towards the choana, that is the nasopharynx. So this is the maxillary sinus. Antrum is the maxillary sinus, choana is the nasopharynx. So the polyp which are starting in the maxillary sinus and progressing in the nasopharynx, and the etiology is infection, these are known as AC polyp. What are the other causes of the polyp? There may be allergy, hereditary factor, the bilateral ethmoidal polyp. We all know the ethmoidal polyp are allergic in nature, and they have a strong hereditary predisposition. Then comes cystic fibrosis, where there is chloride ion transport dysfunction. And because of this chloride ion transport dysfunction, the cilia function is affected. There will be defective ciliary function. Leading to accumulation of mucin into the sinuses, leading to blockage of osteomeatal complex, and again the hypertrophy of nasal mucosa. And the last cause is ciliary dysfunction. There are a lot of pathologies or predisposing factor contributing to formation of polyp, like the DNS, deviated nasal septum, concabulosa. Concabulosa is an oversized middle turbinate filled with the air. Then comes the inferior turbinate hypertrophy, bilateral then comes the cystic fibrosis, then comes the any foreign body, maybe sometime leading to blockage of the osteometrial complex. Now let's start with ethmoidal polyps. So ethmoidal polyps are multiple polyps. They are generally bilateral. That means both sides of nasal cavity are affected. They are allergic in nature. They are multiple. Multiple means they are all around. They are expanding into the all sinuses. That is a maxillary, frontal, ethmoidal, and sphenoidal. So ethmoidal polyps are the polyps which are mainly having the strong hereditary predisposition, allergic in nature, bilateral, multiple in number. They are starting from the ethmoidal sinus, then extending into the middle meatus, going into the frontal recess, coming into the maxillary sinus, and going down into the nasopharynx or the sphenoidal sinus. They are generally involving the middle age group. The AC polyps, if we talk about, they are more common in the children's because of the infective etiology, whereas the ethmoidal polyps, they are generally in the middle year age group, like the 20 to 40 years of age group. So if the ethmoidal polyps are present in a younger age group, suppose younger age group like 5 to 20 years, so we should have to rule out the cystic fibrosis. Cystic fibrosis is a defect in the chloride ion transport. Okay, so rule out the cystic fibrosis if ethmoidal polyp are present in a younger age group. In cystic fibrosis, there is a genetic defect in chloride ion transport leading to thick mucus secretion, leading to mucus stasis, predisposing to the infection, and whenever there is an infection occurring, leading to osteometrial complex blockage. So what is the test of cystic fibrosis? A raised sweat chloride test is diagnostic, that is greater than 70 milliequivalent per liter. So sweat chloride test we will do, and we will find out the increased chloride in the sweat. So that is a test for cystic fibrosis. Then other condition for the ethmoidal polyp is the Churg-Strauss syndrome, which is also known as eosinophilic granulomatosis with polyangiitis, where the multiple blood vessels also get inflamed along with the granulomatous pathology and increased eosinophil count. So that is also associated with the multiple polyps. Now look at the diagram. So this is the middle turbinate, and this is our nasal polyp. You know, this is the allergic polyp filled with mucin. It is an hypertrophied mucosa. So this is a typical picture of allergic polyp. They are usually multiple in number, and the picture, this is shown only unilateral, but these are multiple. So investigation of choice for the nasal polyp is NCCT, that is without contrast. We will do the CT scan of paranasal sinuses without contrast. And what is the treatment of choice? Treatment of choice is FES. So we will do the endoscopic sinus surgery. We will do the removal of all the polyps from all the sinuses, that is a maxillary, ethmoidal, sphenoidal, frontal. So we will clear out all the sinuses. Why this is functional? Then we will widen up the ostium and maintain the normal functioning of the sinuses. So after FES, we will advise the patient to do the frequent steroidal irrigation by means of nasal spray or by means of nasal irrigation. So FES is the first treatment, and complete treatment is FES followed by the steroidal irrigation. Why steroidal irrigation is important? Because we know the ethmoidal polyp are allergic in nature. So once you do the FES, you can remove all the polyp, but you can't completely remove the disease because it's an allergic in nature and it has hereditary predisposition. So there is always a tendency of the mucosal hypertrophy leading to further polyp. So after FES, after opening up of all the sinuses and having a good sinus drainage, what we will advise the patient, we will give an local steroidal spray or local steroidal irrigation. And we all know the local steroidal irrigation will have least side effect as compared to systemic steroids. So that's why the local steroid preparation are preferred over systemic steroid, because systemic steroid will definitely have certain side effect over the kidney, over the liver, over the heart, etc. Now the next is enteroconal polyp. I have already explained that this polyp is mainly the cause is infective. Because of the infection, the osteometal complex will get blocked, leading to formation of mucosal invagination, mucosal hypertrophy, leading to formation of polyp in the maxillary sinus, because entrum is entrum, which is the maxillary sinus, and this polyp will come out from the maxillary sinus and typically descend into the nasopharynx. So these are the polyp which are coming out in the nasopharynx. We are examining the oral cavity. We can see the polyp coming into the oral cavity from the coming into the oropharynx from the nasopharynx. So this is also a CT scan picture where you can see the maxillary sinus filled with AC polyp. The opposite maxillary sinus is normal. You can't see any other polyp, whereas in the ethmoidal polyp, bilateral disease is there. But in AC polyp, unilateral disease is there, and all the polyp are starting from the maxillary sinus and descending towards the nasopharynx. So, localized, unilateral, important, nasal polyposis following blockage of osteometal complex due to anatomical variation like the concabulosa, Heller cell or DNS. What is the Heller cell? The Heller cell is a cell which is present, it is a type of ethmoidal cell which is infraorbital. So this is infraorbital ethmoidal cell. So suppose this is our orbit and these are the ethmoidal cell, and this is my nasal septum, this is my nasal cavity. Okay, so this orbit, so here the cell is present at the infero-medial margin of the orbit, Heller cell. It is in the roof of the maxillary sinus. So roof of the maxillary sinus, infero-medial margin of the orbit, the ethmoidal cell is known as Heller cell. Okay, so here the most common etiology is infection, and it arises from the maxillary antrum, goes into the choana, better seen on posterior rhinoscopy because it is present in the nasopharynx, so you can see this polyp from the posterior rhinoscopy. Again, the investigation of choice is non-contrast CT scan, NCCT of PNS. Now, what is the differential diagnosis of certain polyps? Ethmoidal enteroconal polyp, we have already explained. Ethmoidal is bilateral, allergic in nature, hereditary predisposition. Enteroconal polyp is mainly unilateral and arising from the maxillary antrum going into the nasopharynx. The differential diagnosis, any polypoidal mass in infant. So don't think of only ethmoidal polyp or AC polyp. We are talking about infant, that is a child with an age group less than 1 year. So if any nasal polypoidal mass is present in the infant, you should think of encephalocele or meningoencephalocele. Encephalocele is an invagination of brain tissue. Meningocele is an invagination of meninges, or meningoencephalocele is a herniation of the brain tissue along with the meninges into the nose. So in infant, if there is a polypoidal mass, we should think of encephalocele or meningocele or meningoencephalocele. Sometimes polyp can be confused with a concabulosa or any foreign body. Yes, so that is also a differential diagnosis. What is concabulosa? See, concabulosa is an hypertrophied or a bigger size of middle turbinate whenever there is an air cell present in the middle turbinate. So because of this air-filled cavity in the middle turbinate size becomes bigger. And whenever it's bigger, it can obstruct the osteometal complex, or the sinus ostium opening can be blocked by this middle turbinate known as concabulosa. So this is also one of the differential diagnosis. The unilateral polypoidal mass in young boy, you can be think of angiofibroma. If the unilateral polypoidal mass with a history of bleeding is there, so we should think of JNA, that is juvenile nasopharyngeal angiofibroma. If unilateral polypoidal mass is present in elderly, here it was in young boy, here it is elderly, so then we should think of malignancy. So if in elderly age group, we should think of malignancy. If it is of young boy or juvenile age group, we should think of JNA. So what is the investigation? The investigation NCCT. PNS. Okay. Well, these are differential diagnosis of AC polyp according to the age also. So there is one important sign, that is the crescent sign or dot sign. So in AC polyp there is crescent sign. Suppose this is the maxillary sinus and suppose this is the AC polyp. Okay, so what happened? What is the crescent sign? We will do a CT scan. What we can see? We can see a air of column. We can see a column of air between the mass and the wall. And the wall may be in the sinus or maybe in the posterior pharyngeal wall. Okay, so that sign is known as crescent sign. So crescent is somewhat like this, no? So air column is present. Above there is a mass and there is a layer of air in between the wall of the sinus or posterior pharyngeal wall and between the mass. So this sign is known as crescent sign or dot sign. And also we can do the X-ray lateral view of nose. And what is the treatment? Treatment is again that is a functional endoscopic sinus surgery supported with the antibiotic.